Good morning. We'll get started. Welcome to a second week of in-person Respirology rounds. We have got a real double Dutch delight in store for us. The first speaker, I practiced your name actually quite extensively because I knew you as Hans, but it's Dr. Johannes Cornelius Clemens Maria in Veen. So I got it right. Known to his friends and colleagues as Hans in Veen. He's a respiratory physician at the Franciscus Hospital in Rotterdam in the Netherlands. He directs the severe asthma program, Asthma and COPD clinic. But we have a long connection going back to over 40 years. You would all know Professor Peter Sturck very well, a friend to many of us. Hans did his PhD thesis with Peter in Leiden. And in those days, in the early 90s, late mid-90s, there were only about 5 groups in the world looking at airway inflammasatory processing sputum. And he pioneered this with Peter and Elizabeth Bell in the Netherlands, Philip Int at the Hammersmith, John Fahey in San Francisco, Freddie here, and there were just a couple of other groups. And subsequently, he moved to Rotterdam, where he set up the severe asthma program. And he has contributed immensely to understanding of asthma, measurements in asthma. But over the years, his interest has shifted slightly. He does a lot of primary care alliance work, and COVID presented an opportunity to further implement his expertise in remote monitoring and telemonitoring in management of asthma and COPD, which is what he is going to share with us today. All yours, Hans, and welcome, and thank you for coming to our rounds. Thank you.
Thank you very much for your kind invitation and for your kind words. Indeed, it feels welcome. I've been here 25 years ago, meeting Freddie Hargreave and discussing sputum, and also with Anne Ftimias, this, if I pronounced correctly. So these were challenging times, and it's great to be back. Thank you very much. My name is Hans in Veen. In Veen means like in the peat, in the mud, or something like that. I didn't like that much, but Dave Singh recently said it's like in the whiskey, the peat. So I enjoyed that move. I hope I can tell you something about eHealth, and especially about the clinical aspects of eHealth, also related to obstructive lung disease, but also some general ideas about it. There it is. I have maybe disclosures not concerning this lecture. We're going to discuss eHealth. Do we need it? Because that's the first step. If we need to change, we have to feel that we have to change, otherwise it won't work. We'll discuss a little bit the definition, the scope, and expectation. Good morning. We will also discuss, does it work, and who do we need? If time permits, I'll show a little bit of our research we just started about eHealth and asthma and COPD, and I'll give a small future perspective. I hope later on we have many questions. I'll try to be in time. First of all, do we need to change? That's the first really step. Do we need eHealth? And that's a question, at least in Holland, many physicians say, why do we have to change? We are doing well. If you see here, the Commonwealth Fund, the comparative health care system scores, you see that the Netherlands, but also Canada, is still high in these scores. So if we're doing well, why change? You see that the US is a little bit behind. But Norwegian is at least in this score system, the best performing healthcare system. So no change, because when you're winning, don't change the team. But we're facing many challenges. First of all, healthcare, we need to pay our healthcare, and you can see here, these are the figures of 2019. On the lower side, Canada and the Netherlands almost the same, spending about 11% of their gross domestic product to healthcare, but that'll increase rapidly. For instance, Canada now is on 13%, and in 2014 it will be doubled. in the Netherlands and in Canada. So that's bad news. So we need something to alter our healthcare system to make it more payable. The USA is doing even worse, and the cost will be 3 times 2019. So we have a financial problem, but we also have a problem regarding healthcare professionals. With the aging population, that will increase from 16 to 24%. That is one thing, they'll need more care, but also if there are more aged people, then there are less younger people who can carry on with the work. So workers in healthcare now is 1 out of 7. In the future, in 2040, it will be 1 out of 4. So also there is a challenge. So financially, like healthcare workers, and we have another issue, the environment. Especially now we notice that the many problems we have, and if we can provide our healthcare on a distance with telemonitoring, with eHealth, patients don't have to move to the hospital. And this is a Dutch calculation. If we prevent only the first hospital visit, so this excluded the GPs, then it'll save 1 million kilometers a year. And that's also in Ohio, the Wexner Institute saw the same. They saved in just 1 year about 80 million, a billion, I have to say, kilometers a year. And that's a lot of carbon dioxide. And with that, also, there will be no traffic jams and there are no parking problems. And it's financially also for the patient something to discuss. So if we can do telemonitoring and teleconsultation, that'll also improve environment, besides the other 2 I already mentioned. So we need to change. But is the future clear? Do we know what's going to happen? When I was young, when I was a medical student, I think 50% of the jobs we have today did not exist then. So if we look from today on with eHealth and all the technology, I believe within 10 to 15 years, our perspective will be completely different. And when I discuss this with medical students, I don't think they realize the impact of eHealth and the technology on the future. And it will be rapidly changing within the 10 to 15 years. And what I will show you is that on all aspects on a patient visit, it will change. Just as a matter of thoughts, because I'm not a futurologist. First of all, we don't need a front desk anymore. Because of course, and this is happening everywhere, there is patient identification by deep face or iris scan. But also, the computer can read the patient's emotions, and they can read the emotions better than we do. You see here, I visited the Microsoft campus in Seattle, and they characterized me as well, a little bit violent, but sociable and obedient dog after a while. So it must be correct, but fearful, trusting, or anxious, or whatever, the computer can read it better than we do. We don't need a doctor or whatever to take a patient history, because our avatar is better in taking his patient's history. It has been proven that, for instance, children better discuss their problem with a human character, like a cartoon, than to a doctor or to a nurse. So we don't need us to take history. Of course, the computer or the avatar shouldn't be like a T-800, the Arnold Schwarzenegger, I'll be back type. That's on the lower side. That's a robotic, but fear-giving character. We don't need to take a history. If we want to interpret the patient, what he's telling us, then you need semantic interpretation, because one word can mean different things in different contexts. But nowadays, computers can do that quite well. And if we're working on differential diagnosis, I really like this paper. It was on the ERS 2 years ago. And it was judging whether the doctor or the computer with AI can interpret the pulmonary function better. And it shows that the computer outweigh the doctor in all aspects, in quality, but also much faster. So we're not needed in interpretation as well. And if we want to confirm a diagnosis, we can, for instance, use the spiral nose, E-nose, exhale there. We can differentiate between later on, maybe between asthma, severe asthma, the potential response on biologic therapy, COPD, and even the chance for lung cancer. Some publication pending now. So we don't need us for confirmation. Drug delivery. In Holland, we now start, even though the Netherlands is small, we start drug delivery by drone. And I can understand that in Canada with remote areas, that a drone will work even better. If we want to treat a patient, we don't need physiotherapist or dietary support. We can all use smart instruments, smart glasses, smart shirts, even smart socks, smart belt, and etc. etc. As long as it's smart, it's catchy. I'll discuss a little bit later on smart inhaler devices, which are, most of them are not that smart. It's just electronic dose counter, but some are even better by judging the type of inhalation. So, and next consultation, we are not needed either, because you can see IKEA has a chatbot, but they are rapidly improving and can support us in patient follow-up. And even nursing is, you can see here on the slide, we were no nurses needed anymore. And last but not least, and that's really hard, in the end, the patient falls in love with the chatbot, not with us. So future will be completely different, and this is just one way of thinking of it, but future will be not this, but it will be different. What if we don't change? That is a risk. We will be outnumbered by a private practice or by other colleagues or by whatever companies. We need to change, and we need to stay ahead. And are we on track in pulmonology? I don't think so. If you see on the left side the number of publications, the number of studies on artificial intelligence and on telemonitoring eHealth, you can see that pulmonology is it's marked somewhere in the middle, and you can see the magnitude of the pulmonary impacts studies. So we are not there yet. We have to make many steps, not only in showing that it works, but also in validation. I'll come back to that later. First of all, a little bit of definition. It's actually quite simple. eHealth is the use of information and communication for health. So if you make a phone call, that's already eHealth. So it's that basic. So it can be from just a phone call to many aspects with all kind of telemonitoring and interesting devices. The telemedicine is delivery of healthcare services at a distance. For instance, the drone delivery is also actually telemedicine, but normally it's communication technologies. And telemonitoring is the monitoring of patients at home. So these three are not interchangeable, but they have a large overlap, and the eHealth is some sort of container, some sort of umbrella. The kind of telemonitoring and eHealth really depends on the setting. This is a Dutch slide, but I think you can read it. Dutch is not that hard. I'll try to explain it in English. It depends really on the setting. For in the middle, you see the ICU. There you need close monitoring, like heart rate, etc. If you step out and you go to the ward, then it doesn't need to be that close anymore, but you still want to know, for instance, saturation. And if the patient, after extensive surgery, goes home, you might want to observe directly at home. And in chronic care, in asthma and COPD, you actually want to improve self-management by eHealth. The patient really has to learn to feel their own disease and act on it. Because if they keep on coming to us, then it will be more and more work, and self-management is the way into the future, and eHealth is helping in that. The eHealth itself is not the means, but it's a way too. So from direct monitoring to self-management support. And if we focus on obstructive lung disease, there are several questions we have to ask ourselves. Is there a gold standard? And Professor Freddie Hargreaves in this would be, we need them really very much, because we don't have a gold standard, we don't have great validation, and all studies are, you can't compare studies, because all eHealth support systems are different, and even during studies, protocols change because the technique improves. So you can't compare, you really can't compare studies quite well. Are there legislation issues? Is eHealth better than the regular healthcare we have? Is it cost effective? And are you and we ready? That's still a question of a matter of debate. And do we have the same expectations? If we don't have the same expectations, patients, healthcare providers, but even government, then we're not on the same page, and then it won't fly. Is there a gold standard? You can see here the digital health market in the US. It's rapidly increasing with many apps, and I believe there are more than 400,000 apps in the App Store, and I don't think they're all quite well validated. I'll give you two examples of interesting apps you can't use anymore because they are kicked out of the App Store. But on the right side, you see the blood pressure monitoring by your iPhone. You don't need a cuff. You just put it here, your iPhone, and it will measure your blood pressure. Of course, it's complete rubbish, but people were paying $5 to get access to the app. And the other one is the brain training app used for Alzheimer's disease. And the trick was actually that you should not forget to get out of your app and close it. Otherwise, you keep on paying and paying and paying. So that's in Alzheimer's disease a bit disturbing. So they had to pay some money back, but still, there are many apps, and only a few are well validated. And this validation is very important. You see here on the left side the ISO criteria, class 1, class 2, and even above that, and that's essential. It's if we use an app in a hospital, we need to have an ISO classification, and it means, for instance, that on the left side you see a meditation app that has less impact than an app that says you have to drink water and you have to drink water, and that has little impact as compared to an app that says you have to take your medication, you have to look at your asthma action plan, you have to go for prednisone. So these are decision support systems, and that are almost to the right side for both of us. And that's why the EU is trying to validate with a label. And that's what you can see on the right side, the product, whether or not it's validated, whether it's privacy secured, whether there's assurance, technical and clinical, and if it's easy to use, because that's also a big issue. So we need anyway, all apps that we use has to be validated, at least in this respect. But also, if you realize that hacking problems and computer hacking, it's hacking, yeah, well, I just realized that it's an interesting name. Well, anyway, if you've got a data loss and you have a problem, for instance, in the Netherlands, a large university got rid of all his data and had to pay many millions of dollars to get back, especially the research data. So there are also legislation problems. If you, for instance, want to start eHealth, you always will get discussion with your privacy officer of the hospital. Does it really work? And that's really a hard question. I'll give a short overview of several of asthma and COPD. Here you can see the overview for asthma. And if you're above the horizontal line, then it has positive clinical effects. And there are only a few studies that prove that eHealth support does work in asthma as to asthma control and quality of life. Especially a Dutch study by Jaap Sont, was from the group of Peter Sturck, could prove there were positive clinical effects. But most studies don't show any positive effect, except for that patients really like the app and feel more comfortable with it. And this is a study, a Dutch study, that shows also that it's really hard to prove the usability of eHealth, because it's almost never a control design. This also is an open study where there's a patient at home. Their CCQ in this respect was measured twice a week. The data went to a medical service center, and they were sent the questions and the problems to the doctor or nurse in the hospital. And if you look at COPD on the lower right, there was no change in hospitalization or number of hospital days. And there was a 50% cost reduction. But this was an open study, and that was one issue, and the comparator was 4 visits a year at the hospital. So if you monitor at home and you go for eHealth contact and for phone calls or video calls, of course, patients won't be there in four times a year in the hospital. So the comparator is very hard, and healthcare insurers want to show with this kind of studies that it works, and we can't say that. If you go for a systematic review that was published 2 years ago, then I just copied the results here, and they say there's a positive tendency. The cost effectiveness and the interventions have contradictory results, and it's non-inferior. It seemed safe, but it doesn't seem better. The same for asthma, COPD, heart failure, cancer. It's a safe option, but it's not better. There's one study in oncology that shows that telemonitoring and eHealth support improves outcome if you look at emergency hospital visits. Telerehab is also an issue. This is a study recently performed, but the results also from a Greek group in 2017 are the same. You can see here the CRQ, the 6-minute walk distance, and the endurance cycle test, and there is no difference between the group. There's rehab and from a distance, the telerehab. There's no difference in 3 groups, so it's possible, but it's not better. If you can use this because of long distance, then it might work, it might come in handy. Then the question is, are we ready? First, the patient. If you look at the internet penetration in Europe, then the Netherlands, I don't know how it is in Canada, but almost everyone has a smartphone, almost everyone has internet access. But that's only the access, the way to go to internet. The second question is, of course, can patients handle the digital era? And we know that about 30% in Holland, and that's all around Europe, so I expect it's also here in Canada, has health literacy problems. So even you have access, then you have to cope with the new situation, and you can see that on the small cartoon on the right side. So the patient, is he ready? But is he willing? That's also a question. This is the monitor in the Netherlands just before COVID. So that has changed now in the COVID era, because patients realized that also teleconsultation would work in the COVID pandemic. And if you look at the lower bar, you'll see that still more than 50% don't want to go for teleconsultation. And the orange bar is don't know, whatever, don't need it. And 20% say, I won't do it. So the patient, is he capable and is he willing? That's an issue. But the same issue counts for the healthcare provider. Nowadays in Holland, about, let's say, and the specialists are more conservative than, for instance, nurses, if you can see, but we already knew that. But about 60% of the pulmonary specialists are willing to start with eHealth. So that's still 40% that don't want to. And we have to realize that even also this group of healthcare workers want to start with eHealth. 1 out of 5 healthcare workers is not capable of working with eHealth at the moment. So there is also a lot to win. And we need the healthcare provider and the patient, because it's actually eHealth is not a substitute, it's blended care. And as you can see here on this graph, we have an asthma and COPD eHealth support system. And you can show on the green line that with healthcare provider support, the patient will adhere much more to the eHealth system than when it's just for the patient alone. That's 13 against 70% adherence to the eHealth support system. Are we on the same page? Patients do want to discuss the disease, so that's interesting. If you make a group of patients, they can chat with each other. They want to measure and share data. Doctors also want to measure, but they don't want the responsibility. So patients want to measure and doctors want to measure as well, but the patients want to discuss the data. Doctors don't want to see it actually, but only want to measure it and use it during the consultation. Patients also want the mastery, the being in control, and they really prefer also the fast e-consultation within such an eHealth system. The healthcare provider wants to control adherence, especially medication, alarms, but no responsibility. And I think that could be a great advantage for eHealth support systems, a more efficient consultation, because the patient can prepare her or himself at home for the consultation. The government wants something completely different. They want every care out of hospital, and also actually from the GPs, everything back to informal care. They want to control and have cost reduction. I don't think they'll get cost reduction, but we need eHealth to lower the cost for the future, so it won't increase. And ICT companies, well, they are looking for money and big data. You can see, for instance, Fitbit. You can't use Fitbit this year or next year anymore without a Google account. And we don't use Fitbit in our research because data are not owned by ourselves. We can't have access without Google. And there's also a hosting issue. If we in Europe want to perform eHealth studies, then data cannot be stored in the USA, for instance. They have to stay in Europe due to legislation and privacy. But ICT companies just go for big data and money. What to do for eHealth implementation? And this is an old slide, but I still like it. It's the Rogers 5 factors of success. We always have to, when we start to go for the really digital transformation, that's something else actually than eHealth. Really digital transformation is working digitally instead of doing the things we did on an internet basis. Is it better than we have? Does it fit in our workflow? Because it has something to resemble, otherwise we can't make the change in our brain. It's not too complicated. Can we try and modify it? Modification is also important. And can we see that somewhere else it does work? So, and being a copycat. These 5 factors of success seem to be quite important for implementation, as well as, of course, well, I already mentioned the simplicity, but the connectivity of systems. Many systems work on an island. I don't know what kind of hospital information system you have. Is it internet-based or is it on paper?
We have electronic medical system, which is not the best in the world.
Okay. Epic. Okay. Well, we're all searching for the Holy Grail, of course. In Holland, we have also Epic some hospitals, but they have to be connected with each other, but also with all the healthcare hospital systems and with the GP. And there are, I believe, 10 systems for GPs, and GP won't get rid of their own system. They will more easily divorce than get rid of their system. So there has to be integration. It has to be also refundable, because if you do something different, then you have to pay for it. And in Holland, in the COVID area, teleconsultations was possible and was refunded. And nowadays, government is changing back to saying first consultation has to be physical. So that's a major drawback. But these 5 factors seem to be quite important. I will show you 2 studies we just started, in which we used eHealth or telemonitoring. I'm on schedule. We're trying to estimate the adherence in COPD patients for their inhaler, and we want to compare whether a single inhaler patients are more adherent to single inhaler therapy than in loose triple. And that's the single inhaler therapy compared to the multi-inhaler, and we compare the adherence in a multi-center study by using a device that's put on the dosage aerosol. I'll show you the design. What we want to do actually is further validate also adherence in COPD, because there are many discussions. We know that adherence is low in COPD, 40% are some data. We want to validate the questionnaire. There are questionnaires that measure adherence, but that's patient-based. We want to compare that to the data as delivered by the drug as dose counter. And we want to compare it by really the absorption by hair analysis. You need some hair on your scalp, and we cut it off, and then you can measure beclometasone, and you can see whether or not the questionnaire, the dose counter, or finally the dosage in the hair is the same. This is the design, and we'll use triple therapy in all 3, but in the first one it's 2 different inhalers. Bevespi is glycopyrronium formoterol versus beclometasone extra fine. And then we've got the Trimbo, that's the 3 molecules in one. And the third group is also the triple therapy in one device, but then with internet support, with dose count, and with also an alarm, hey, you have to take your medication. And the question is, which group is better? And for all 3 groups, we measure the adherence in the hair, in the questionnaire, and you can see on the right upper side, it's a finder, it's a Polish device, but it's well validated. It's put on the aerosol and it counts the dosage. But it's not actually a smart inhaler, because it does not measure the correct inhalation. It does only measure whether or not you fire the inhaler. This is the internet support system we use. It's a platform with support for questionnaires. You can see on the screen, for instance, the CCQ. There's a smoking stop program for. I was amazed, by the way, by the cannabis smoke smell in Toronto. I smelled more cannabis in this weekend than in all my life in Amsterdam. So that's interesting. But it has also lifestyle suggestions. It has a frequently asked page. It also has support for how to use your inhaler, and it has the e-consultation. So this is what we're just going to start, and we want to measure whether or not there are a difference in these 3 groups. Another issue is we just starting nowadays is the expert asthma COPD trajectory at home. In the Netherlands, in our hospital, we have a multidisciplinary consultation. We are the referral center for 13 hospitals. You can see that in the circle on the right side. These are consulting our hospital, and we discuss whether or not the need for biologic therapy. And we want to check whether or not the multidisciplinary consultation is better or equal, or can we even after the multidisciplinary consultation find treatable traits that will improve patient care and might alleviate the need for biologic therapy. So all patients who are eligible for biologic therapy will go into the study if the patient, of course, is willing and gets a biologic therapy or goes into the exact at home to say where we measure all kinds of issues like exercise, adherence, medication adherence, I'll show in a second, but also FeNO at home. And we will compare that after 6 or 12 weeks with the group that directly start on biologic therapy. And even we will go for breath pattern analysis. This is what we'll do in the active arm. So this is not the biologic arm. The active arm first gets internet support with all the appliances I already mentioned, but also an activity tracker that is well validated. We use the DigiHealer of Tiva that has not only a dose counter, but also will show you whether or not the device is properly used. We'll go for handheld spirometry at home, and even if the patient has a high FeNO, for a FeNO meter at home. This will be done in 6 weeks, and then we'll decide whether or not there are treatable traits that has to be improved. For instance, if the patient is not adherent to inhaled steroids, that has to be done first, and we'll compare it with the group that starts with biologic therapy with the Tiva inhaler, but without alarms. And what we hope is after 12 weeks, then that there is an improvement also of self-management in the patient, and that the patient who is now sitting in the back of the boat and the healthcare provider is rowing, they will change places because the patient stops smoking, losing weight, etc., etc. So that's two studies using internet and eHealth support we start nowadays. But the future, we need to think what's happening in the future. And on the right side, you can see all the issues we can potentially measure, also by telemonitoring. It's many data, and these data will be merged into a computer. And we should think about how to handle all these data, because it's many data. I believe in the study I just showed you, Exact at Home, we have 1 million data points a day per patient. So that's an immense number of data we have to analyze. And we're discussing that, and we need some nerdy doctors together with IT nerds to sit together and discuss how to do and how to cope with all these data and define algorithm and have treatment adjustments later on. Of course, first you have to harvest the data and then go for an algorithm and see what happens. That's something that's, I think, the next couple of years the most important issue we have to face regarding implementation. An interesting issue I don't want to leave out. It has just been published, and I think it's interesting because it states the different way of work we will have in the next 10 years. It was a suggestion in the JMIR, and they suggest we should revise the Hippocratic Oath in the digital era. And I really enjoyed this paper because it empowers researchers and patients, as you can see in the first line. But if we have more data, we should also benefit the healthy and not only the sick. And we have to realize that the patient is not a disease. We don't use the surgeon's knife to the chemist's drug or the programmer's algorithm. So the patient first and the algorithm second. And we have to respect the patient and their data. It's the complete privacy, and we should not disclose that. And the last one, I will never treat a patient just only as being a data point or an algorithm suggestion. So that all implies that the future is made today, but we're changing rapidly. And as a take-home message, I always liked this slide because we are with IT specialists, with the Epic guys, we're discussing something completely different. So we have to really focus on what really we want to have. Thank you very much.
Thank you very much, Hans. I mean, lots of this might sound like science fiction to us. We still heavily depend on the fax machine, at the Firestone, and we just recently got rid of the old rotary phone. So this all sounds very science fiction, but I'm sure there are many colleagues at the university who have implemented telemedicine. In our own group, there are attempts to implement telemonitoring for pulmonary rehabilitation. I do not use much, but there are colleagues who use this. So before we open up, let's see if we have got questions in the chat. We'll take some of the remote questions, telemonitoring. Martin Kolb, excellent presentation, rapidly changing field of medicine. Thank you. I would like to comment on the patient experience as a physician. So could you comment on that, please? This is all fine. Yeah. Is there data on what patients think about this, particularly broken down by the severity of their disease? So milder patients, mild monitoring, not so acute, this might fine, but what about patients who have very severe disease, what particularly lungs? So could you comment on that, please?
Well, that's an interesting question. And of course, nowadays we have to focus more and more on the patient perspective. So that's an important question. I'll go into the severity in a second. What I think is what we see in the patient experience is that they prefer the internet support, but it doesn't lead to better quality of life or better healthcare. But they feel stronger, and especially that's an issue. They think they're properly monitored, but that's not always the case. The patient think that there's always a doctor or a healthcare provider sitting behind a computer and watching the data of the patient. And that's not true. What we need in the future is telemonitoring nurses and that's especially if the size of telemonitoring increases, then telemonitoring nurses can watch and monitor many patients on a screen, and that would really improve not only the experience for the patient, but also will in fact assure the safety of the monitoring. The severity of always shown that patients, there's a patient profile, the patients who we want to be in control adhere better to eHealth programs. So it's a form of mastery. The patients who are looking for mastery, that are really preferred eHealth and telemonitoring. And the severity, I can't mention that. That's an interesting question. There are patients with severe asthma who completely deny the disease, and I don't think they want it, but they need it. And there are patients also who are very anxious, and then it really can work because it's a safety field.
We could discuss that offline, but Chris Allen, who raised a question, perhaps might articulate it better. Chris, do you want to ask the question yourself?
Yes, can you hear me?
Victoria has unmuted Chris there. So, Chris?
Can you hear me now?
Are you there?
I can't. Can you hear me?
I want to ask a question. Yes. How do you
can't
ask
hear
the
me,
question?
can you? You can't hear me, can you?
I have no idea. I'm terrible at this.
I'm
Answer live. What do you do, Mark? Do you know? Do you have any idea what to do? How does he come online?
Now we see already the challenges.
It says I can hear Chris. Someone in the audience
can you hear me now?
How does that work? Just answer live.
That one, yeah.
What's that? Where is the audio? I don't. Is that muted? I thought it was on.
It must be on because we are on screen.
Chris? Can't hear you, Chris. Sorry. Very sorry about that. The people who have signed in can hear him, but we can't. I've got no idea how to do this. Do you? No? I thought you're the IT, but I have no idea. Anyway, so another colleague from Guelph, Jackie Nemni, has this question. We have spent so long insisting on the importance of doing spirometry, and then we are asked to look after them without being able to assess them, examine them, or get spirometry. What are your thoughts on that?
Well, that's an important question. For COPD, it's maybe not that interesting because it's what we see for chronic and obstructive. But still, there is one system that has shown a reduction of the exacerbation that uses spirometry, temperature, and questionnaires. That's the Monitor system. I think, especially in asthma, spirometry is an added value above questionnaires. Well, it depends, of course, if the patient really senses their obstruction well. If it's a poor perceiver, you even need spirometry at home even more. This question states that we need integration of systems. The problem is that when you have, for instance, a movement monitor, it's a standalone. Spirometer meter is standalone, and you need integration of the exercise. You need the obstruction and the questionnaires, and then we're making a step. So
further. Have you implemented what you've shown in research in clinical practice? In Holland, you have home spirometry, home enometers, and home monitoring for areas.
For orphan disease now, it's like pulmonary fibrosis. There is home monitoring with spirometry. In asthma, it isn't, and we're now making the first step. And the problem is again reimbursement for a simple asthma. The hospital gets reimbursed €300, and a spirometry device costs €120. So that you can't afford it unless you have some agreement with the insurer to do so. But it's not mainstay in the Netherlands, unfortunately. Okay. I agree with the question.
Yeah, go ahead, Jeremy.
Fascinating talk, and it's not much space, but it's definitely very interesting to understand this is the future coming. And a lot of us was a focus on people that have already been diagnosed. And I'm curious about where eHealth and health, whatever health you want to call it, plays in the role at the point in time of diagnosis, and if that's actually like an early intervention to convert the recently diagnosed to then adopt, this is the path, and could that potentially be changing the trajectory?
Yeah.
This and again, it's hard to test when you compare it to someone that gets eHealth at the time of diagnosis. I mean, is there any data around time of diagnosis rather than treatment and the role of eHealth?
There's very little data about it. But as I showed you in the last study, we tried to use, for instance, home monitoring or spirometry to see whether or not one of the problems we see is vocal cord dysfunction. And to compare that with real obstruction spirometry, especially if it's work aggravated, we can use home spirometry and work spirometry for that. But there are not much data about before the diagnosis. Monitoring, yes, and also in defining treatable traits. And for instance, I really liked I just read about the Parkinson's disease. They discovered that patients with Parkinson's disease don't type with the app, they use verbal, and that's because typing is hard, and they designed that if a patient with Parkinson's disease types, they can see whether or not it's fatigue or it's muscle problems, and whether or not the disease is progressing. So in progress, there are studies, but not in the very first start of the disease. No.
Because where the question is stemming from, and we did a support group here with IPF.
Yeah.
And we had some human-centered design type of approach. We were just asking, what was your journey during diagnosis? Yeah. And the qualitative outcomes were such that they felt that they weren't in control and didn't have power. There were uncertainty there. So the patient group was saying if only you were put on a trajectory of knowledge, confidence and mastery to use the word. They felt like, even though it's a perception, which isn't necessarily an improvement of quality of life.
Yeah.
But there is that.
Perception is perception.
Yeah. Perception. So I'm just wondering.
So just to repeat for the audience, Jeremy Hirota was asking the question of using the merits of this at the first point of contact, as opposed to the journey of a patient through a disease, and what the evidence is. That was what is being discussed, because this may not project well to the people who are listening in.
Well, indeed, in IPF now, Rotterdam, Marlies Wijsenbeek, and I showed one slide of her, is using indeed home spirometer to see the trajectory, but on forehand, that's hard. But we also know that severe asthma patients, it takes 7 years to be at the correct specialist. So we're seeing only the tip of the iceberg. And I think with also with data from maybe the move monitors, the Fitbits, maybe you can extrapolate later on to see which group is what, and then you can improve your diagnostics and see which patient has a problem. Yeah, but not today, unfortunately. Yeah.
While we are getting the audio sorted, can I ask another question? So how good is telemonitoring and eHealth to diagnose and monitor conditions with a huge differential diagnosis? So I'll give you 3 examples. Someone comes to you with shortness of breath, headache, fatigue. So those 3 symptoms, how would remote monitoring and machine learning algorithms go through those very broad symptoms? Other examples, if you have a firm diagnosis, asthma, COPD, yes, but fatigue, headache, shortness of breath, which we struggle with, how does these systems compare?
Well, some of the telemonitoring, as I mentioned, the spirometers at work, for instance, can help in that, or the Veen at home. But if the differential diagnosis is too broad, then you can only focus on several aspects. You can exclude or prove. But if the differential diagnosis is too large, then you first have to reduce several steps. Yeah.
Because that's exactly what we face in our severe asthma clinic. The true severe who have short of breath may not be due to asthma, and this is where our system fails, because we fail to consider other conditions, such muscle disease, for example, that algorithms may not pick up unless they're built into algorithms.
Yeah. I agree, and that's
why as good as what you put into it.
Yeah, garbage in, garbage out.
Yes.
Yeah. So true. No, but that's why we're starting the study, to see whether or not we can anyway see other treatable traits, whether or not even is it asthma, because I mean still 20% of the patients with severe asthma don't have asthma.
Yeah.
So that's the first step, of course, confirmation of the diagnosis, and maybe you can then differentiate later on. But you can also use these data then for discussing the issue with the patient, because for instance, when I say you have to go for exercise a little bit more, then they say, well, who are you to say? But if the meter says you're not doing exercise, but it's all integration of data, and that's why we need AI.
Okay. Yeah. Any other questions? Oh, there's a question here in the chat. Speaker, if you'd like to ask a question live. Chris, do you want to try? Go once more. Chris?
Forget it.
Oh, but then he put, I think it's working now. Chris, are you still there? Oh, I think he got frustrated and probably left. The question is, as a patient, speaking for myself, the remote experience is inferior. The physician uses a phone. There is no visual contact and the experience is impersonal. Breakup with the cell phone gets in the way. EMR is full of inaccurate information. As much as 30% of the time is spent correcting the information. The whole consult seemed to take twice as long. How do you ensure the accuracy of the information?
First of all, I agree with that. Telephone consultation is not. It's not easy to discuss really specific but deep problems. It's for shallow conversation, but you can use video consultation. We use that. I was the first one in the Netherlands to go for video consultation in 2013, and really that failed on integration, because every time the system had an upgrade, then the video consultation crashed. But video consultation, you can see anyway the patient, so that, in my opinion, has an advantage. Still, it takes more time than a personal consultation as an outpatient. So I agree with, it's more time consuming, and it really helps if you know the patient, and the patient especially knows you, because you have the right code of the patient, and he knows how to discuss things with you that'll improve. But it's more time consuming, so true.
Yep, sure. Go ahead.
Do people miss the physical visit to see the doctor? Does that know?
From my personal experience, well, especially with the COVID area, a problem with no physical consultation. I have many patients who will say, "I'm happy to see you live again." So it's also here blended care. You can go for a video consultation, telephone consultation, but you also need the in-person contact, especially if you want to discuss personal problems. Yeah.
On that note, there is a bestseller by Abraham Verghese. Many of you would have heard the name, physician in San Francisco, who came to fame during the AIDS epidemic, who wrote this bestseller called Cutting for Stone, who emphasizes in his TED Talks, I really encourage you to listen to his TED Talk, I'm sure you'd have listened to this, about the personal touch, how the severe patient feels comforted by the patient touching them. And he advocates and he talks about the pros and cons of losing that touch of a caring physician.
Trust is a really important issue in any treatment, and while doctors were trusted by patients, therapy works better.
That book, I encourage people to read. I mean, in this age, it's very relevant. Any other questions?
I get the placebo effect also kind of goes with that.
Sorry, say that.
The placebo effect that you RCT the electric trial also goes with the fact that the patient feels cared for, and there's more adherence medication.
I agree. That's why we need randomized trials anyway, to better judge the effect of telemonitoring in eHealth. Well, anyway, it's not. It seems safe, but there was many concerns in COPD. There was a disease support system. Veen, maybe you know the name, wrote about it, and they saw that mortality in the patient who had just a remote support, the mortality was higher. So we need more studies anyway.
Right. Formally, thank you,
thank you
for your wonderful talk and insight into the future. I should also emphasize that you mentioned about cutting fuel costs, and Hans is a strong advocate for air quality, and he sits on the Dutch Lung Alliance and on the European Lung Foundation board, and he's a strong advocate for clean air. Thank you again, Hans,
thank you
for visiting us. Thank you.
Great to meet you.
We'll take a small 5-minute break, and then in a few